Good morning, everyone. Ladies and gentlemen, my name is Dr. Hardik Gandhi, and on behalf of Zydus, I welcome you all to this webinar on dermatology practices during the COVID-19 outbreak, being conducted in collaboration with the Sri Lankan College of Dermatologists. To all the viewers, I request you to please post your questions in the Q&A section available with you, and our speaker today will address all the questions from the audience directly at the end of this session. Before we begin, let me take a brief moment to introduce Dr. Akarawita. Not that it is required, as is already a known personality in the Sri Lankan medical fraternity. Dr. Janaka Akarawita is a consultant dermatologist at the National Hospital of Sri Lanka, Colombo, and he was the first in merit at the selection examination for MD Dermatology. He has been awarded the Dr. D.A. Gunawardena Gold Medal for the best paper in dermatology, and he has delivered several presentations and lectures at national and international forums. He is also a member of the academic bodies across the world in the field of dermatology and has held office positions in the Sri Lankan College of Dermatologists, including being the past president from 2015 to 2017. He also represents Sri Lanka in the South Asian Regional Association of Dermatologists, Leprologists, and Venerologists. Sir, it is a pleasure to have you with us today, and over to you, sir.
Thank you very much, Dr. Gandhi, for that kind words of introduction. Actually, I didn't expect such a long introduction. I think you can hear me.
Yes, sir. Yes, sir. Yes, sir. Over to you.
Just let me get back to the. I think good morning to all of you. So this COVID-19 outbreak has changed so many things in our lives. It has changed our lifestyle, the way of meeting, and so that that is why we are meeting electronically today to discuss what has changed in our dermatology practice due to this COVID-19 outbreak. Actually, now this knowledge regarding COVID-19 disease is rapidly changing, so that these things which I am talking may be changed or different after a couple of months. For example, actually, when this epidemic occurred in Sri Lanka in mid-March, our unit, we got together and searched for any dermatological manifestations, whether there have been any publications, but we couldn't find anything much important other than the exanthematous rashes, etc. But now recently, there have been so many dermatological manifestations being described. So don't know whether they were not described before, or whether they were not there initially in China, the Hubei province. So actually, I am not still not directly involved in managing COVID patients. We don't know what will happen in future, but so that this information I am going to talk about from the different journals and the other sources where I found certain important aspects, and so I have summarized those information so that you can get them in a summarized form. So I'm going to talk about different aspects which has affected to our dermatology practice. So pathogenesis and skin manifestation of COVID-19, and choice of immunosuppressives, and also novel skin manifestation in the medical staff, and safety measures and changes which has occurred in our practicing methods as well. I'm going to talk a few things about them as well. Now, to start with, I will go through a few things about pathogenesis. Now, we are not managing these patients directly, but better to know about the pathogenesis to some extent. And so that again is evolving area. So this is the coronavirus, which causes the disease, and this is the electron scanning electron microscopy, which shows the virus moving in between the cellular compartments. And it is, as we know, it is a multi-system organ involvement disease, including most of the systems in the body. And the postmortem findings done in some places have shown that when in the epidermis and the dermis, the viral particles can be found. And also one important thing I want to emphasize is it may be excreted where the tears as well, where sometimes we happen to examine the patients where we may touch than the nasal secretions and the respiratory secretions. So to talk about pathogenesis, I went through several articles, and I have grabbed few things from these articles, which are, some of them are actually not in the press, but they are available online for us to go through. There is initial the entry is through the endothelial cells, the respiratory tract, and it binds to the receptors, and that is how it enters the cell, the body, and it induces innate immune hyperactivation. So, and lysis of pneumocytes, and giving rise to various protein particles which are generated in this process. They activate multiple innate immune pathways. This inflammatory cascade can cause viral control as well as tissue damage. So, they have suggested that insufficient activation of type 1 and 3 interferons, or the inadequate increase in this concentration, may contribute to the innate immune failure, and so that viral persistence can occur. And elevated levels of serum IL-6 have been demonstrated along with LDH and some other immune chemicals. And so that is why some occasions tocilizumab has been used as a treatment in severe cases. And out of the specific immune system, the helper cells play a critical role, mainly the Th1 and interleukin 12 and type 1 interferons. These are important because some of our biologics act on these cytokines, and so that when we are treating our patients and who has COVID infection, these effects may be considered. Not only that, Th17 and Th2 and regulatory populations may also be involved to some degree in this immune reaction. So in severe disease, cytokine storm occurs, which can damage our own tissues. So these patients are those at highest risk of multi-system failure and significant mortality. Males and those with pre-existing hypertension or coronary disease are at higher risk of severe disease and consistent with known correlates of AC expression. So these two graphs show what happens to the immune reaction. So the top one is where acute or controlled viral infection. So most of the times we know the patients recover and only a small minority of patients will go into the severe disease. So in most of the patients, this is the immune response which occurs. So red is the innate activation and the blue line is the adaptive immune system activation and the light green color is the viral load. So you can see initially the innate immune system gets activated, then the adaptive immune system, and which persists probably, and the viral load goes down. But in chronic or uncontrolled viral infection, this innate immune system activation persists and cytokines are high in amount in the body. Then the adaptive immune system sometimes goes into failure, causing immunosuppression and lymphopenia. So sometimes in these patients, we see lymphopenia. And T-cell exhaustion can occur, leading to persistence of viral load. So that is a bit of a summary of immune reaction in COVID-19 infection. And one important thing relevant to us is with when our patients have epidermal barrier interruption like atopic dermatitis, psoriasis, and so they may be at a higher risk of viral inoculation or getting the infection as well, other than the fact that they are on immunosuppressives. This is another new article which focuses the light on other aspects of these reactions occurring with COVID-19. So it can be other than the inflammatory overactivity, it may be vascular dysfunction, thrombosis and dysregulated inflammation may be causing the severe symptoms. There are several factors they have listed as evidence for that. Increased respiratory dead space suggests lung vascular thrombosis and microangiopathic changes causing thrombosis and pulmonary embolism. And the high increase of D-dimer levels, and sometimes expression of antiphospholipid antibodies, etc. So immunosuppression, endothelial activation, and direct viral mediated tissue damage rather than hyperinflammatory injury mediated COVID-induced organ dysfunction can be the cause for severe disease, according to this article. This picture shows the complex description in a summary. I think it is too complicated to go through all minor points here, but you can see that virus enters through the AC2 receptors, and there are certain changes occurring in the AC1 receptors that have been shed, and changes in the AC2, giving rise to changes in angiotensin. So angiotensin levels initially increases, and so leading to various pathological processes. I have highlighted in a purple color what is probably more relevant for skin, because these things may be the cause for some of the skin manifestations, the pathogenesis of the skin lesions. So endothelial damage and microvascular dysfunction. Those may be especially related to the libido-reticle brain manifestations. So we will move on to skin manifestations of COVID-19. So there are several manifestations described. So this article, which describes about 375 cases with skin manifestations. So they have analyzed those patients from Spain and categorized the skin manifestations into 5 pseudochilblain or acral areas of erythema, edema, and vesiculation sometimes, and sometimes vascular formation. Then this widespread vesicular eruption. So the pseudochilblain has been there in about 19% patients and vesicular eruptions in about 9%, and urticaria lesions, urticaria in 19%, and other maculopapular eruptions, something similar to viral exanther, in about nearly half of the patients, and livedo reticularis or necrosis in about 6% of patients. So we will go through those individual entities. Before that, I just want to show this, which was circulated in our WhatsApp group once. There actually, this is a poster from AED. It shows, in addition to the other manifestations, the petechial rash. So that also can be one of the manifestations in patients. So actually, I think Dr. Nayani had mentioned that still from IDH, there were no these specific skin manifestations being reported. So, but anyway, sometimes we may happen to see these manifestations in our patients as well. In addition to those 5 categories, a few patients showed other manifestations such as inanthem and purpuric flexural lesions. So there again, they also mention about purpuric lesions. So dermatologists also perceived an increased number of herpes zoster cases in these patients. So I'm talking about this study done in Spain, taking 375 patients. So we'll go into those 5 conditions. Pseudochilblain is purpuric areas, especially in the hands and feet extremities. Usually they are asymmetrical. Pain or itch may be the presenting symptoms. It occurs in younger patients and lasted for about 12 days. And it occurs in the latter part of the course of the disease, that is the COVID-19, and associated with less severe disease. So luckily it is associated with less severe disease. Then the vesicular eruption occurring in about 9% of patients, 9% of the patients who have skin manifestations. Actually, many of these patients may not have skin manifestations. One Italian study had shown about 20% of patients in them had skin manifestations, skin eruptions. But I think from China, we couldn't get much reports of skin manifestations. So this in vesicular eruptions, some of them can occur over the trunk. They are small monomorphic vesicular lesions. So in contrast to chickenpox, so they are sort of similar to chickenpox lesions, but they are monomorphic. So that is one important feature. Then in the limbs, they may be hemorrhagic and become larger or diffuse. So you can see that in the picture. And itching was a common feature, and it occurred mainly in middle-aged people, lasted for a mean of 10 days, and it appeared before other symptoms. So that may be a presenting feature. And actually, I read one article where the pseudochilblain, or called Ovid toe, had been a presenting feature of a COVID patient to a dermatologist, and later on diagnosed to have the virus being positive. So again, so this these vesicular lesions also can appear before other symptoms. This is associated with intermediate severity. Urticarial lesions, again, in about 19% of patients, mostly distributed in the trunk or can be dispersed, can have few lesions on the palms. Other maculopapular eruptions, it's in majority of skin manifestations, this had been the presentation. Varying degrees of scaling can occur in some patients. It's like just a maculopapular eruption, viral exanthem. A few cases showed infiltrated papules in the extremities, mostly dorsum of the hands, that look pseudovesicular appearance. Then few things about these two manifestations, urticarial and maculopapular lesions, both showed a very similar clinical the associated findings, which lasted for a shorter period, 6.8 days, around 6 days for both conditions, and usually appeared at the same time than the rest of the symptoms. Compared to the rest of the symptoms, it appeared at the same time. It was seen in the little bit of more severe disease in the group where the 2% mortality was seen. Itching was very common for urticarial lesions and as well as maculopapular eruption. The fifth one, livedo reticularis or livedoid necrosis. The degrees of lesions suggesting occlusive vascular disease, so including areas of trunk or acral ischemia. It has occurred in older patients, so we know in older patients the mortality rate is high. It is about 10% in that group. It has been demonstrated, but had been variable, including transient livedo with some suffering mild COVID disease, so who were not even admitted. So a few more things about this skin manifestations. Severity of associated diseases followed the gradient from less severe, like in pseudochilblain, to more severe in the livedo reticularis presentation. Patients in the group with urticarial and maculopapular eruptions were receiving other drugs more commonly than the other groups. So whether it is associated with drug and the viral infection is a possibility, like in other exanthematous eruptions or the urticarial eruptions. Most of the urticarial and maculopapular lesions might not be very helpful for diagnosis, so because there are many other common causes for these conditions. But monomorphic disseminated vesicular lesions and acral vesicular pustules or the pseudochilblain are probably quite specific, and their appearance is coherent with the lesions in other viral exanthems. So these conditions sometimes may lead to as the skin first manifestation and the diagnosis of the condition. So there are a few other things they have mentioned about this presentation. It is unusual that a single virus can lead to several different clinical patterns, like especially as different patterns do not coexist on the same patient. Some hypothesized to explain this polymorphism may be that some of them have alternative causes or differences in the virus or the host. The fact that some of the lesions, even in confirmed patients, are similar to other viral infections, and the perceived increased number of herpes zoster cases raises the hypothesis of some of these being the result of co-infection, and whether this co-infection is due to the coronavirus infection, which led to the co-infection. These two pictures actually I received today in the morning from Dr. Durani. So I should mention that a few of our postgraduate trainees working in UK, where epicenters in Europe, and some of them are involved active management of COVID suspected patients. So this patient has presented about 2 days back with this urticarial eruption. So other than those skin manifestations, there are certain other presentations which we have to be concerned of. So this is one case report which appeared a couple of weeks back. COVID-19 and Kawasaki disease. This is one patient case report. So on day 2 of fever and erythematous, seemingly non-pruritic bronchic rash has occurred. And on day 5 of fever, had limbic sparing conjunctivitis, prominent lung papillae, a branching polymorphous maculopapular rash, and swelling of the hands and lower extremities, all features of Kawasaki. Thus meeting the classic criteria for Kawasaki disease, and it has been managed as like in Kawasaki with IVIG, and the patient was positive for COVID-19. Not only that, now this is a news item describing a rare syndrome affecting children that could be linked to COVID-19, has been reported in several European countries. Children admitted to intensive care with a multi-system inflammatory state. So I think in about on April 27th, the British Pediatric Association had described about this presentation in UK patients, in children. They were displaying overlapping symptoms of severe COVID-19, toxic shock syndrome, and Kawasaki disease. So these cases have reported in UK, France, Italy, Spain, and US as well. Not all have tested positive for COVID-19 at that time. So this is another article which has been written on May 2nd, 2 days back, by one of the virologists. 19 cases have been identified in children in UK, and 100 cases have been identified in 5 other countries in Europe. Severe abdominal pain, GI illness, and some also have fever and skin rashes. So we have our involvement there. So they are. The syndrome appears to be similar to Kawasaki disease, which involves inflammation of blood vessels. So typically, the disease occurs in children under the age of 5 years and can lead to coronary artery aneurysm and permanent heart damage if not treated. So it's similar to Kawasaki. The syndrome is treated with intravenous IVIG, aspirin, and steroids in severe cases. There is a type in error, it should be IVIG, aspirin, and steroids. The UK, some of the critically ill children showed active COVID-19 infection. Few did not appear to be infected. It is thought this may be simply because these children has already cleared their infection. A theory that is supported by finding antibodies in some of the children who were tested negative for the PCR. This suggests that new syndrome may be an inflammatory reaction that occurs during the recovery period after the COVID-19 infection, when the COVID symptoms have resolved. So those are the, I think, the manifestations of COVID up to now described, which may involve us for the skin manifestations in patients. So now, there are certain things which we face day-to-day practice, that is choice of immunosuppressives for dermatology patients. Now, we have actually a whole lot of patients who are on different immunosuppressives. So this is American Academy of Dermatology guideline, which was issued a couple of weeks back. I will just go through a few things mentioned there. So I would like to highlight about this, continue to provide the best possible care for patients with skin disease. So we have to keep our patients, our dermatology patients at the best possible care. To keep our patients out of emergency rooms so that they will not end up in the emergency rooms where they can get infected. Urgent care, or not to burden the healthcare system unnecessarily. So we should not trouble with the emergency people, with our patients. Delicately balance the risk of immunosuppression with the risk of disease flare, requiring urgent intervention with patient-specific risk. Therefore, the academy strongly recommends that patients should not stop their ongoing systemic immunosuppressive therapy without consulting their physicians. So they have categorized the patients into 4 categories. One, patients on systemic immunosuppressive agents who have not tested positive or exhibited signs or symptoms of COVID-19. So we have to use our clinical judgment and think about the indication, why we started immunosuppressives and the severity of the disease at the time we see, or I mean at the current time, and other associated risk factors like age more than 60 and having other comorbidities. So we have to consider all these factors in deciding on the management of immunosuppressive or alteration of the immunosuppressives. Then the patients on systemic immunosuppressive agents who have tested positive for COVID-19 or exhibited signs and symptoms of COVID-19. So that is possible infection is there. So then we have to discontinue or postpone until patient recovers from COVID. So we should not discontinue prednisolone or other steroids because there can be certain withdrawal issues, but otherwise the other immunosuppressives have to be discontinued, or if possible, if it is unable to discontinue, we have to postpone until patient recovers from COVID infection. Patients who have halted systemic immunosuppressive therapy after testing positive for COVID-19. Sometimes by the time they reach us, this may be the situation. So recommends after complete recovery of COVID-19. If we consider new patients for systemic immunosuppressive agents, then again we have to assess the risk versus benefit, and for lower risk patients, we can go ahead with initiation of immunosuppressives for dermatological diseases. So the high risk population, so in these patients, we should not consider immunosuppressive therapy, to avoid as much as possible. Individuals above 60 years and older, or patients with recognized comorbidities such as cardiovascular disease, diabetes, severe hypertension, liver disease, kidney disease, respiratory system compromise, internal malignancies, or tobacco use, etc. So there may be other situations as well where we have to consider patients as high-risk people. Then few things, this is from few other AAD articles or letter to editors. I have taken a few extracts from them. Use of biologic therapy is known to modulate and blunt Th1 responses, including TNF alpha blockage, and then other interleukin blocking agents like ustekinumab, which blocks interleukin 12 and 23, may especially require more stringent precautions to diminish risk of infection and prioritization of alternative therapeutic agents when possible. So we have to always think about alternative therapies. The effect of IL-17 inhibitors like secukinumab and dupilumab, which blocks IL-4, is predominantly impair Th17 pathways and Th2 pathways respectively, remains unknown, and for now also warrants caution. Some of them say that it's okay to go ahead, but still we have to be cautious about it. But cyclosporin, azathioprine, methotrexate, and also steroids warrants precautions because they suppress the immunity in a wider manner. So there are several theories regarding the severe COVID infection, the tissue damage, etc. So clinical data also paradoxically suggests that further deterioration in infected patients may be the result of a pro-inflammatory state created by cytokine storm. So by inhibiting the intensity of the cytokine storm, immunosuppressants may prevent lung tissue damage and further clinical deterioration. So that is some opposite view for the people or the patients who are on immunosuppressive. Actually, these things sometimes we may be analyzed later on what happens if these patients get infection, whether they go into severe disease or not. This is a chart, again, a letter written by a dermatologist to the editors. So he has grouped the therapies, immunosuppressives, which has no effect on viral immunity, including secukinumab. We have few of patients who are on those on that biologic. And group B is theoretically effect on Th1 or viral immunity, but no actual increased incidence of viral infections while on drug. So that again, there may be lesser risk of using them, ustekinumab and apremilast. Then slight increased risk of infection in general, including viral infections. So those are the TNF-alpha blockers mainly, and the other interleukin blockers. Then the broad-based immunosuppression, which would increase risk of infection, including viral infection. So that is the traditional immunosuppressives, where we have to be very cautious on using them on our patients, including prednisolone, methotrexate, cyclosporin, azathioprine, and mycophenolate mofetil. So now we will move on to our next area. I'm going to talk about the skin manifestations in the medical staff. So the mainly it is due to this protective clothing, the personal protective equipment. The main effect is hydration effect, friction, and those things leading to epidermal barrier breakdown and also contact reactions. It may, these factors may aggravate an existing skin disease as well. So there may be erythema, papules, maceration, scaling. Those are the most commonly reported features, especially over the friction sites, nasal bridge, the cheeks. They may complain burning, itching, and stinging. They may develop contact and pressure urticaria, contact urticaria, pressure urticaria, and sometimes dermatitis from wearing N95 mask, and aggravation or induction of acne. This is one example where this erythema has occurred over the cheeks. Actually, Dr. Ajit Kanangara had a journal suggesting to name this as COVID-19 MS sign. So that is demonstrated in this picture. So the protective hats may induce pruritus on the scalp and folliculitis or seborrheic dermatitis. And the long-term use of protective gloves can lead to maceration, erosions, and leading to contact dermatitis. And exaggerated hand washing with detergents can impair the acid mantle of the skin surface and also may be responsible for irritation and contact dermatitis. And for them, it is recommended to apply hand cream or moisturizers frequently, especially following hand washing and before putting on the PPE. This is an example of irritation over the hands. So few tips for the staff who wear the PPE at home. Before you leave for work, wash your face and hand, or maybe have a good body wash, and dry thoroughly. Apply moisturizers to face and hands. Should be completely absorbed, not to allow to remain on the skin. And when you go to work, before putting on the PPE, again apply skin barrier, wipe to dry over the forehead, nose, cheeks, etc. Leave it for about 1.5 minutes so that it is not sticky with the PPE, and then put on the PPE. So those few tips to prevent this manifestation. So now the other aspect is safety measures in the clinical practice. I think this is an area where we can discuss in length. I learned that some of our colleagues in peripheries have already started to exit from the curfew, and so in Colombo and the Western Province, probably from next week or afterwards, we will be gradually coming back to near normal situations. So Sri Lanka College of Dermatologists, the committee has formulated the guidelines as exit strategy for dermatology units. I think there is soon that will be circulated among the members. So actually we should appreciate the effort of this committee who had to prepare this within a very short period, and it is a very comprehensive and extensive guideline. I am not going to list it here or talk about it because some of the things already we are following up, and you can go through it. And again, IAD they had similar instructions being given to their members. This letter was circulated about several weeks back. Actually, I just selected few things there. So they say to minimize direct walk-in patients, and when giving appointments, you can seek brief history by WhatsApp or email, etc., not to confront the patients. And then teleconsultation, so they promote teleconsultation as well. So those are a few things I wanted to highlight. And so what is happening? So I think so there are so many other aspects where we can consider in safety measures in the clinical practice. We have to think about the safety of the patients. We should not allow them to congregate in our clinics. We have to think about the safety of staff, and also we have to sort of think about safety of the patients with dermatological diseases, so that we should not allow our patients to get severe and end up with the complications. So there are, I mean, as I mentioned at the onset, many things have changed with the COVID-19 epidemic. Changes in practice in style and method. Survey done including 842 physicians in USA has shown that 48% of physicians responded reporting that they are now treating patients through telemedicine. So telemedicine was in discussion for several years. Actually, we wanted to have guidelines, and we wanted the Sri Lanka Medical Council to get involved in this and having regulations, etc. But now we are in a situation where we happened to all of a sudden we happen to enroll in this telemedicine in a larger scale. So this is another assessment, including dermatologists, 60 dermatologists, their practices. About half of their offices, so the clinics, were open. 31 out of the closed, the others, 31 were only seen urgent patients, 16 were closed. In New York, they said 20%, only 20% clinics were open, which was the lowest proportion of any county in USA compared to the other areas in US. So conclusion is many practices have restricted their level of operation, especially in higher areas of COVID-19 prevalence, likely to help facilitate social distancing. So few things, few areas. This is a vast area to discuss in detail. What are we doing during this period, during last maybe 2 months? Actually, most of us do not see patients. We have drastically cut down seeing patients. I'm talking about the government sector as well as private sector. So that is what has happened. So we have limited our clinics, but furthermore, the curfew or the situation in the country has limited the arrival of patients to our clinics. So we are comparatively seeing very little patients during this period. And much more audio and video consultations are being done. Sometimes it is done as a fee levied, or otherwise sometimes it is done as a free consultations. Many of us are enrolled in that. And WhatsApp is being used for this as a method of communication and seeing pictures, etc. And when we are physically have imposed certain changes or regulations which we did not like earlier. So no bystanders, only the patient comes in, and minimal time with the patient, minimal touch, and with maximum distance. And we don't want to perform procedures, minimal procedures. And sometimes our examination techniques have changed. So generally, we tend to touch the any lesion when a patient comes and presents to us, but that has been restricted now. Only essential situations we have to touch. Then again, we have to wear gloves. And sometimes we may use different techniques. For example, if you want to check thicker nerves in leprosy, better to approach the patient from behind and examine rather than doing it from the front of the patient to avoid confrontation face to face. So those, that's an example. So we may need to follow different techniques compared to the previous era. I think I have come to the end of my talk. I know that there are so many other areas where we can talk in length, but due to the time factor, I have curtailed to this. Thank you for your attention.
Thank you very much, sir. May I request you to please stop sharing your screen so that we can start the Q&A session. Thanks a lot, sir. I think, in this session, you've covered, while you started from pathogenesis and skin manifestations, but then, you gave some important experiential insights on choice of immunosuppressives, particularly for the vulnerable populations. And then going on to the manifestations in the medical staff, particularly due to the use of PPEs. And also the most interesting part about the changes in current clinical practice and the increased embracing of this telemedicine in the current scenario. So, sir, thank you for all these sections, and I think you've covered a lot of cleared a lot of confusions in the mind of several people attending this webinar. If I may seek your comments on assessing patients, particularly who may be at risk of contracting COVID-19 when they are suffering from skin or sexually transmitted infections.
Can you repeat?
Yeah. So,
That?
sir, as a dermatologist, how would you
Yes.
assess the risk of COVID-19 in a patient who is already suffering from a skin or a sexually transmitted disease?
Yes, actually now, so this agent is in action. So in the hospitals, in the government sector, at the OPD, there is a questionnaire actually regarding the symptoms, etc. So that is the first thing every patient goes through, and in the private sector as well, they do the same thing. And so in that, they consider the travel abroad, the area of residence, and contact with anybody having symptoms of COVID or the positive cases, and whether the patient is having those symptoms at the time, etc. So that in any suspicious situation, they will be diverted to the COVID suspected units. Then that's one thing, and some places they measure the fever, no temperature, measure the temperature by the non-touch apparatus. So the temperature may be sometimes helpful, but most of the COVID patients are fever free, and so that it may not be very sensitive method. But anyway, it is also being practiced. So that is what is happening for each and every patient. In addition, actually, we have thought that is in our clinic, we are planning to do it when the curfew is lifted, again to do the same triaging, because there may be patients coming without going through that process. And so that is the main way of detecting them. And when they come to us, again, we have to always recheck with the history and recheck with the patient's current symptoms. Sometimes they may not reveal what really they have.
Thank you, sir. That is a useful insight. Sir, you have discussed in your presentation at length about the dermatological manifestations of COVID-19. An interesting question that has come up globally is differentiating this COVID-related rash from the dengue-related rashes. So, if you can share some comments on that.
Actually, now this vesicular eruption and the pseudo-chilblain, they are more specific for the COVID patients. So they are like, so they may be sort of more specific, which we don't see in dengue patients. But petechial rashes and the exanthem. So exanthem and the petechial rashes can be misleading, definitely. So exanthem can occur with even other viral diseases. So they are not considered as specific for COVID patients. So in that case, actually, we can't rely just on this clinical features. So we have to go through the other history and the other symptoms and other systems patient has got involved. Furthermore, actually, now we had in Sri Lanka as well, we had a few cases. I got to know that initially they have low platelets and also false positive for dengue antibodies, so that so that they are being treated as dengue patients, and then later on only found to have COVID. So that has been reported in Singapore as well. So there are several journal articles as well describing this feature.
Right, sir. Sir, in your presentation, while you were discussing about the use of immunosuppressive agents, you had grouped the immunosuppressive agents into 4 categories. And my next question is based on that. This morning, there was a case report in the Journal of European Association of Venerology. That is, there has been a report on the incidence of COVID-19 in a psoriatic patient who was being treated with an IL-23 inhibitor. So, what are your comments on about patients continuing biological drugs like IL-23 inhibitors and TNF inhibitors in particular in this scenario?
Actually, if they get infection, according to this situation, we have to postpone the next dosing. So until they completely get clear out from COVID-19. So sometimes we may experience a disease flare. That's one, and that is actually the main situation. So if possible, we may go for other treatment modalities like cipratin in psoriatic patients. If it is possible, actually the real practical situation is in these patients who are on biologics, actually they have tried all the other non-biologic treatments by the time they they have been started on biologics. So that is a big issue. But anyway, they are demonstrated to be positive with COVID-19. It is recommended to stop temporarily until they come out of the disease.
So drawing on that same comment from you, so sir, if you have a patient who has been treated with a non-biologic treatment and you were considering them to be put on biologics now, so do you think this would be a good time to start biologic therapy in those patients?
This is not a good time actually. Several issues now. When we start on biologics, they have to be on it for a longer time, and so their effects come a couple of weeks later. I'm talking about the therapeutic as well as the immunosuppressive effect, and so then actually we don't have a strong hold once we inject the biologics regarding the immunosuppression. So even in a normal situation, our most dreaded concern is whether the patients will get any infection. So in such a situation, in COVID-19 background, better not to start the biologics if you can avoid them. So that is the recommendation, and we can try with the other measures as well to maximize the other treatment measures.
Right, sir. So just one last question before we bring this webinar to an end. What are, as a dermatologist, what advice would you give to your general patients regarding skincare in this scenario?
Yes, I want to add on something more. Actually, if it is, say, now, if this situation goes on, we may face that there are patients whom we need biologics. Without that, there is no way out. So in that situations, we may consider starting them. But again, we have to see whether they are having high risk for the COVID-19 complications. So then again, that will be a negative factor, elderly, having other comorbidities, high blood pressure, ischemic heart disease, and smokers, etc. Then again, those are not considered suitable. But if they are having less risk factors, and if it is really necessary and failing all the other measures, then we may go for biologics. And so the other question was what we advise for the patients. Am I right?
For the general skin care in this scenario.
Yes. Actually, one thing I want to highlight is that we have to look after our patients. So that is one, because So there are so many things in this situation, outbreak. Patients with them, we are afraid to approach the patient thinking that we are getting the disease. We may get COVID-19. Sometimes patients are afraid of coming to the doctors thinking that they will get the disease from the doctors. So there are two aspects. So I think both are reasonable, but we have to keep that fear to a minimal level because we have to make sure that skin diseases are not becoming severe, ending up in complications, especially compared to the others times. We have to minimize that so that the burden on the health sector is kept minimal because the emergency units, the medical units, have to handle COVID-19 patients. So that we should try to help them by keeping our patients under control. So that any patient who think that the condition is getting severe, there should be some access, medical access, and so they should come. But same time, we have to educate patients that this is not time just to come for a skin tag or a ward or laser treatment or some scar removal, etc. Now, so that is the other thing. Sometimes that also happens. So we should highlight that though curfew is lifted, it is not safe to travel around, not to gather around, because that person is coming for a simple thing. He is putting himself in risk, and also he is putting the others in risk. So not to gather around. So only for essential issues you come to the doctor. And there are now many places have, even our clinics have numbers, the telephone numbers. So call them and get advice. Sometimes the government is delivering by the medicine by post, and our doctors are involved in that, so they can approach them and talk about and get an advice, and better to get an time to come rather than early morning everybody getting to a gathering in front of the clinic. So they should get a time and feel necessary to come and see the clinicians. And also, I mean, general advice, I mean, the hygiene and social distancing, all those things.
Thank you, sir. Thank you for this very important and clinically useful knowledge sharing session. And I also thank the Sri Lanka College of Dermatologists. Sir, we have a message from Dr. Indira Kavita on behalf of the Sri Lankan College of Dermatologists. Dr. Kavita says that I would like to express our sincere thanks to Dr. Akarawita for this excellent presentation, which covered many aspects of COVID-19 pandemic. And this talk covered many areas that needed to be discussed and a good start for a healthy discussion. And Dr. Indira also thanks Zydus for organizing this conference. So thank you, Dr. Indira. And we are happy to collaborate with the Sri Lanka College of Dermatologists for this session. And I believe this was the first of many knowledge sharing sessions that we will have in the future. So I thank you, Dr. Janaka Akarawita, for this wonderful session and for your time and sharing your experience with all the dermatologists in Sri Lanka. And also, I thank the audience for making this event a success. And I will request all of you to post your feedback for this session, as well as any suggestions you might have for the future sessions that you might be interested in the Q&A section, and we will take it up accordingly. So thank you, sir. And thank you, Sri Lanka College of Dermatologists. Have a nice day.
Thank you very much for involving me in this interesting academic exercise. Thank you.
You're welcome, sir. Thank you. I just wanted to check if